Assalamu alaikum. My name is Rawa Muhsin. I'm a pathologist, and my topic is the role of pathology in the diagnosis of HCC. As our radiology colleagues will later explain, we don't need a biopsy to make a diagnosis of HCC in all cases. It's only when the imaging findings are atypical that we resort to a biopsy and pathology. So this is the general outline. Now, the liver, for our purposes, is composed of a functional unit which is known as the lobule. The lobule is where the central vein, the branch of the central vein, is located in the center, and portal tracts are located at the periphery. So we can break down the entire liver into these functional units. Now, you know that blood flows to the liver through the portal tracts from the branch of the portal vein and the hepatic artery, and then it flows out of the liver through branches of the central vein that eventually go into the inferior vena cava. In between these two structures, we have plates of hepatocytes. So these are the parenchymal cells of the liver. You can see that there are these pink cells which are arranged in thin plates, and they are separated by sinusoids. So why is this important? Because the liver does not only contain hepatocytes, it also contains bile ducts, it contains blood vessels, it contains stroma. When we say hepatocellular carcinoma, we're referring to a malignant tumor of the liver that shows hepatocellular differentiation. If it shows bile duct differentiation, that's called a cholangiocarcinoma. If it shows vascular differentiation, that's called an angiosarcoma, and so on. So we are specifically focusing on malignant liver tumors in which the tumor cells look like hepatocytes. So grossly, hepatocellular carcinoma can be composed of a single nodule. It often has a greenish to yellowish appearance, which you can guess is due to bile production and fat content. But that's not the only appearance. Sometimes it's composed of multiple adjacent nodules, sometimes it's composed of different separate nodules, and sometimes it can have a diffuse cirrhosis-like picture, which is called cirrhotomimetic. So does this have any importance? If you have two separate nodules of hepatocellular carcinoma in the liver, this is usually due to two different primaries, meaning they're not related. But if you have a dominant nodule of hepatocellular carcinoma and there are smaller adjacent nodules near it, this is often due to intrahepatic metastasis of the same tumor. Does this have any significance or any impact on survival? At least in one study, those cases that had this vaguely nodular appearance had a better early recurrence-free survival as compared to the cases that had a diffuse infiltrative pattern. But this did not affect the overall recurrence-free survival or the disease-specific survival, so it's of limited value. What is important to report in the gross section of our pathology report? The tumor size is the most important. Why? Because it affects the staging. Actually, most of the T staging of the tumor is affected by the size and vascular invasion. And we also need to report tumor rupture through the anatomical surface of the liver, because that may predict recurrence or remnant inside the abdomen. Now, the histology. So remember, we said hepatocellular carcinoma is a malignant tumor showing hepatocellular differentiation, meaning it looks like the hepatocytes of the liver. So this, if you show it to a non-pathologist, looks pretty much like the first picture that I showed you of the normal liver. But there are some differences. The difference is that, remember there that I said that the hepatocyte plates are very thin. So you have a layer of hepatocytes separated by a sinusoid, then another layer of hepatocytes. In hepatocellular carcinoma, they become thicker. So you have thicker trabeculae of hepatocytes. The cells start to show some nuclear atypias and pleomorphism. Now, it's not only in this form of solid trabeculae. Sometimes you can have gland-like structures inside a hepatocellular carcinoma. This can cause confusion with a cholangiocarcinoma. But the difference is that these are actually not glands. These are just dilated bile canaliculi within the tumor. They contain bile, and we can use some other features to distinguish them. Now, you know that the liver is a major organ in the body. It has a lot of functions. One of them is production of different substances. Now, hepatocellular carcinoma, just like normal liver, can produce some of those substances. So one of those is mallory hyaline, alpha-1 antitrypsin. It can appear as these eosinophilic globules inside the tumor. Another one is fibrinogen, which is involved in the coagulation cascade. So the cancer can also produce a lot of that, and it will appear as these pale bodies. Now, you know that the only cell in the body that can produce bile is the hepatocyte. It has nothing to do with the bile ducts or the cholangiocytes. So a hepatocellular carcinoma can also produce this bile pigment. In fact, I remember a case that we had in which the tumor was so poorly differentiated, you couldn't even tell it was a hepatocellular carcinoma. The only clue was that there was bile production inside the tumor. And that gave us the idea to do the immune stains, which were relevant to make the diagnosis. Now, there are other features like the sinusoids separating the normal hepatocytes become like capillaries so we can stain them. We have aberrant arterioles which are not accompanied by bile ducts. How do we grade hepatocellular carcinoma? Well, there are 4-tiered systems and 3-tiered systems. The one that we most commonly use is a 3-tiered system. So you have well-differentiated, moderately, and poorly differentiated. When do we say well-differentiated? When it looks like a normal liver. In this case, it's difficult to distinguish from benign lesions, and we'll get to that in a moment. While for the poorly differentiated, it's difficult to tell that it is of liver origin. You know that it's cancer, but you can't tell if it's hepatocellular, and you need to do immune stains. Sometimes the grade, or actually oftentimes, the grade is not homogeneous. So when you take a biopsy, you're looking at a very tiny portion of the tumor. But the tumor may show intratumoral heterogeneity. So one area of the tumor may be grade 1, another area may be grade 3. There is actually good correlation between biopsy findings and resection later on. But it's important to keep this in mind. If I tell you on the biopsy that this is a grade 1 hepatocellular carcinoma, and later on you send me the resection and I say, well, this is grade 2, you shouldn't ask, well, how did that change happen? It's the same tumor. There are areas which are well-differentiated. There are areas which are poorly differentiated. This is an example of such a tumor. This is a well-differentiated steatohepatic hepatocellular carcinoma. This one is a more moderately differentiated tumor, so it's losing some of its differentiation. So what are the important histologic parameters that we need to report that has a bearing, or that have a bearing on prognosis? One of them is the grade that we just mentioned. The other one is the stage that I pointed to in the beginning, the size of the tumor, vascular invasion. Tumor subtype we'll get to in a minute. The presence of cirrhosis, which of course you can also tell by imaging, vascular invasion, and CK19 staining. So cytologically, sometimes you do an FNA for a liver lesion. We don't really recommend that. Biopsy is better than cytology for most purposes. But the finding would be just, again, thick plates of hepatocytes which are wrapped by endothelial cells with some pleomorphism. Now, what about small HCC? So small HCC is defined as a tumor which is 2 centimeters or less in maximum diameter. This could be of a progressive or a progressed type, which is easy to diagnose histologically, just looks like a regular hepatocellular carcinoma, and it could be of the early type. The early type is difficult to distinguish from a benign lesion. I currently have a case on hold in which they took a biopsy from a liver tumor, and it's very well differentiated. So I have to take some extra steps to say whether this is cancer or this is a dysplastic nodule. Okay, so we need to distinguish early HCC or very well differentiated HCC from dysplastic nodules. These are pre-malignant lesions. They're not cancer, their management is different. So what are the features that we can use for this? If you have a nodule with a nodule appearance, so you have a nodule, within it you have a distinct area. This distinct area is most likely starting to progress to cancer. If you have invasion of the adjacent hepatic parenchyma, if you have loss of the reticular network, and some immune stains. So this probably looks the same throughout to most of you, but just try to imagine this part at the bottom and going up there, that's the normal background liver. Here, from this point upwards, we have a distinct nodule within the liver. We cannot tell if this is a dysplastic nodule or an early HCC. How do we make the distinction? First, if we see invasion, this area is invasion into the adjacent parenchyma. So this is the nodule, and it's starting to invade. That's one point. Another one is the reticulin network. You know, reticulin is a type of collagen. It has a rich framework within the liver. Normally, it highlights the thin hepatocellular plates. In hepatocellular carcinoma, one of the defining features is the loss of this reticulin network. So just look at the black lines. These are the reticulin fibers. You can see it's very nicely retained there. Here you can see it's broken down. It's lost in some areas. You don't see continuous lines. This means loss of the reticulin network. It's one of the key features of hepatocellular carcinoma. We can use some immune stains that are indicative of malignant behavior. These include glypican-3, glutamine synthetase, HSP70. If you have 2 out of these 3 positive, that's very likely to be hepatocellular carcinoma in an early, well-differentiated lesion. So we have a plethora of subtypes, of histologic subtypes of hepatocellular carcinoma, but do they even matter? Do I need to report it? Do I need to say hepatocellular so-and-so subtype, or should I just say hepatocellular carcinoma? Some of them do, because the clear cell variant and the lymphocyte-rich have a better prognosis as compared to conventional HCC, whereas the macrotrabecular and the neutrophil-rich have a worse prognosis. Now, you may have heard of fibrolamellar carcinoma as a distinct subtype of hepatocellular carcinoma that has a better prognosis. It actually doesn't. The better prognosis is due to the lack of cirrhosis in the background. These are usually young patients who don't have cirrhosis. If you compare fibrolamellar carcinoma to conventional HCC in a non-cirrhotic liver, it has the same prognosis. Okay? There are some unique features of this fibrolamellar, like some unique immune stains and a unique molecular fusion. And this is what it looks like. So I'll just quickly go over some of the variants. So this is steatohepatic. So we have steatohepatitis within the tumor and in the background of the tumor. This looks like clear cell renal cell carcinoma, and we'll need to use immune stains to make a distinction between hepatocellular carcinoma of clear cell type and a metastatic clear cell renal cell carcinoma. Again, we can use immune stains for that. This is the Skirres variant. On imaging, it may look like an adenocarcinoma, cholangiocarcinoma, but histologically, it's different. This is the massive trabecular that we said has a worse prognosis. This is the lymphocyte-rich. This looks like lymphoepithelial carcinoma of the head and neck, only that it's not EBV related. And we can have sarcomatoid differentiation. We can have mixed hepatocellular and cholangiocarcinoma together in the same tumor with intermediate features. So what are some of the immune stains that we use to help us in the diagnosis of hepatocellular carcinoma? First, we have two markers for hepatocellular differentiation. So if these markers are positive, they support a hepatocellular origin to the tumor. One of them is HepAR1, the other one is arginase. We use HepAR1 for more well-differentiated tumors, and we use arginase for more poorly differentiated tumors. Third, we have a marker which not only supports hepatocellular origin, but also its malignant nature. So this marker is negative in normal liver, and it's positive in malignant liver cells. So it's very helpful for cases in which we're not sure if it's cancer or not. We have a number of other markers, like markers that highlight bile canalicular structures, because remember, hepatocellular carcinoma is the only tumor that can produce bile. So it's going to contain bile canalicular structures. We have negative markers, which are important to distinguish from adenocarcinoma. We can use FISH for albumin because liver produces albumin. And regarding keratins, because these are common stains we use for all tumors, liver only gives the CK8 and 18 or CAM52. It's usually negative for CK7, except for the fibrolamellar variant. Do molecular changes matter? First of all, there is stepwise accumulation of molecular abnormalities.
Dr. Rawa, 2 minutes.
Yes, that's enough for me. So there is stepwise accumulation of molecular changes when you progress from a dysplastic nodule all the way to hepatocellular carcinoma. Now, we don't need to the pathogenesis. So some of these include the WNT pathway, TP53, ARID1A, but we don't use them clinically because they're not necessary to make a diagnosis. The only thing that is of clinical value is this DNA JB1 PRKACA fusion in fibrolamellar type hepatocellular carcinoma. There are attempts at molecular classification of hepatocellular carcinoma, just like we have in endometrial adenocarcinomas. So these divide them into proliferation class and non-proliferation. The proliferation has a worse prognosis. It's more poorly differentiated. The non-proliferation is associated with beta-catenin mutations. But again, we don't use these because it's still not clinically relevant. So we're waiting for the oncologist to tell us, well, it does matter for us, so that we can start doing it. There is even an immune classification of hepatocellular carcinoma depending on how inflamed the liver is, the liver cancer is. This is important for PD-L1 therapy. Now, you can see that there are already molecular targets for therapy in hepatocellular carcinoma, but none of them still require testing. So these include kinase inhibitors. They include some trial targets like NTRK and MET. We have anti-PD-1, which we can test for by immunohistochemistry. And microsatellite instability, which is relevant in colon cancer, is not relevant in hepatocellular carcinoma because it's very rare. So in summary, when you say hepatocellular carcinoma, or HCC, we're referring to a malignant liver tumor that shows hepatocyte differentiation, not bile duct, not stroma, not blood vessel, hepatocyte. The important histologic finding is that the hepatocyte plates are thickened and there is loss of the reticular network. The main immune stain markers that we use are hepar1 arginase glypican. The fibrolamellar is a distinct variant that also shows CK7, CD68 staining and this unique molecular fusion. Among the subtypes, the only ones that have a better prognosis are the lymphocyte-rich and the clear cell. The ones that have a worse prognosis are the macrotrabecular and neutrophil-rich, and molecular testing is still not routinely clinically useful. And thank you.
Thank you very much, my dear colleague, for the nice presentation. Next speaker, our great mentor, hardly endeavoring teacher. Please, your stage is yours.